Welcome to June's short in public governing body for Bassetlaw CCG. Apologies from Deepti Alla and Louise Lester. If there's any changes to declarations of interest, please can you allow Lindsay Blaylock to know. Sarah informed Idris and Lindsay and myself yesterday that we've had no questions from members of the public. I can confirm that we are quorate, and also today we're joined by Sally, who's going to do a paper later on infection prevention and control annual report. So welcome, Sally.
Thank you. Morning, everyone.
To commence with quality and patient safety update, Nicola.
Okay, so key issues highlighted in the report. Some of it obviously relates to safeguarding. So the obviously governing body is aware that the safeguarding children arrangements changed a couple of years ago on the back of the Wood review. So Wood's gone back and had a look at the arrangements that have been put in place nationally to consider whether they've been effective and whether the changes that he's recommended were made. So obviously this is just a detail of the report, the full detail. There's a link to look at the whole of it. So I think the report says that there's some really positive things that have happened, but there are still some areas that need to be developed and move forward. And I suppose some of that development will be what happens in the structures of the ICS. So currently the Safeguarding Partnership membership requires that CCGs are in attendance at the board. So obviously that legislation will need to change, or we'll need to look at how that happens in the future. There's obviously quite a lot of independent scrutiny around safeguarding children, or the safeguarding partnership. So we've got an independent scrutineer who's been appointed separately. Previous arrangements, that person was employed directly by the county council. So Mark Peel, who's our independent scrutineer, does give us some challenge and also looks at some key areas on our behalf, and certainly holds us to account, which I think is a lot different to what happened in the past. Currently the CCG is a member of the Safeguarding Partnership, so I attend, and Kathy on my behalf if I'm not able to attend. And as of the next meeting, the chair is changing, and Rosa Waddingham from the Nottinghamshire CCGs will take the chair. So Health will chair the partnership. Again, completely new from previous arrangements. It used to be very county council led. So we are seeing it emerging. It is a challenge at times to keep it quite strategic, but obviously as we go forward, this will be again a key board for us to be part of. Just to note, the modern slavery statement's been reviewed on the website. We are required to have a modern slavery statement, so it's just to note that that's happened. There's not any major changes, just some changes in dates. From a care home perspective, we continue to see no outbreaks. Sally will obviously discuss that probably a bit more in our IPC report, but and we're now seeing visitors going back into care homes, which is really, really positive. And our new audit program's commenced. So there's a selection of us that are visiting the care homes and doing some of that audit work, and we're working closely with partners around that. The LD acute liaison role is now in post and working, employed by the CCG, but working into the hospital, and is developing the ambassador role for learning disabilities across the trust, which is proving to be really positive, because obviously in all areas they'll have an LD ambassador to support individuals that access services at the trust. And Evie's been quite a key person in developing that work, and also supporting making the move to support patients in primary care who access appointments or tests or whatever. So I think it's really good, and gives us some additional LD resource locally. Continuing healthcare, we continue to do well on our standard DSTs, so we're achieving above the national target. As I mentioned last time, we still have some outstanding reviews We've now got a trajectory with Notts Healthcare Trust on how we're going to achieve getting back to a normal process of working by September. We're not at the only CCG. Most CCGs are in the same position for reviews, and our percentage is similar to our partners in SYB. So it's disappointing, but we've got a way forward with that, and people are working really hard to get those reviews completed. Personal health budgets go from strength to strength. So during since the last report, we've had 8 new personal health budgets, and we're getting some very interesting personal health budgets. I'm sure Hesh will comment on it, and supporting people with more complex neuro conditions that traditionally don't fit into standard services. So particularly acquired brain injuries, we're seeing a lot more patients accessing the personal health budget from that perspective. Transforming care, we continue to be above our trajectory for inpatients, although we have got a couple of people that are due to be discharges or discharge dates, so that's really positive. And obviously we're working through the national processes, so we have regular CTRs for individuals that either may require admission or are in inpatient settings. And we've received some feedback on our CTR process, saying asking other organisations to come and look at what we do. So that's really positive. So Hayley, my team, has just taken over that role. So we're seeing exemplar around our CTR as well as our LD annual health checks. And then finally in the paper, the Domestic Abuse Act has now been agreed in Parliament, and includes some additional things, so forced marriage, honour-based abuse and abuse towards gender identity and sexuality. So it's moving away from that typical physical injury approach to domestic abuse into a much wider context. And there is a new clause now that includes children who have actually seen or witnessed or been part of domestic abuse settings are considered to be abused, so they fit into the Act, whereas previously they didn't. So that's really, really positive. And they've also amended offences, so there's a new offence for non-fatal strangulation, and there's an amendment to the offence of disclosing private and personal photographs, which we know has been in the media in the past, particularly with young people and social media. And also there's amendment to the coercive control definition, so that it does include wider people that sit outside of the family setting. The county council are required to have a domestic abuse partnership board, and that's been formed, and we are part of that. We're members of that. So I think from a domestic abuse point of view, the Act's really positive, which I'm sure everyone will support, but actually it gives us a real opportunity now to drive the agenda forward and be part of it with our Nottinghamshire colleagues. And then obviously there's just a reference to the ophthalmology update at the end, which has been already discussed. So I don't know if anybody's got any questions.
Thanks, Nicola. Any questions for Nicola on this? Oh, it's very comprehensive. Thank you. Next, Nicola, Emergency Preparedness, Resilience and Response Annual Report. That's a bit of a mouthful. Yeah,
so we're required to publish an EPRR annual report, and obviously the details in the report, predominantly it's COVID focused, so I'm not going to go over all the COVID stuff because we've talked about it for a very long time. We continue to be an active member of the Nottinghamshire LRF structures, and we obviously both in COVID and outside of COVID, and we're working with them now on recovery. So I don't think, if anybody's got any questions, I don't really want to labour the PRR annual report. We have been made aware that the annual self-assessment will happen again this year. So at some point we'll be bringing that back through governing body. We haven't received it yet, but I've been made aware it's going to happen.
Thanks, Nicola. I suppose my only comment from the report was that actually its full title, I think, didn't appear in it. It was all the EPR abbreviation. So maybe having the full title in at some point.
Thank you. Yeah, no, I'll take that positive comment. Thanks, Eric.
Thanks. Okay, we've got Kathy down for doing learning disability mortality review. Are you going to pick that up, Nicola, or
Yeah,
would you defer?
right. Kathy's on annual leave, so I'm
Right.
sure she'll be sitting somewhere nice. So again, we're required to produce an annual report for Leader and publish it. So obviously this is our annual report. So obviously during COVID, we worked much differently. So Kathy and Terry completely took Leader under their wing and developed some much smarter processes for us, which enabled us to do reviews much quicker and as thorough as before, but in a shorter time frame. So obviously we have had some review Leader deaths during COVID, and obviously they were actioned. We did utilise the national team for some of our reviews because there was concerns around backlogs and obviously the COVID response versus Leader. So we did use the national team. And again, as Kathy's put at the end, we've achieved all our outcomes. We've got action plans that we monitor at our LD group, and also we're in a positive position. We're looking towards what happens for Leader in the new structures because it's changing, and we're waiting to implement the new process once everybody's been trained and the new system's up and running. So Heather Woods is taking the first review. So I don't know if anybody's got any questions around Leader.
Sam, I can see your hands up.
Just a general comment, Nicola, and I think just to thank yourself, really. You know, everything's felt like business as usual, and I'm sure Sue will add to this that, you know, from Quality and Patient Safety Committee, I think governing body can be assured that everything has continued as normal, and that's thanks to your leadership, Nicola. So much appreciated.
Thank you.
Yeah, I'd echo that.
Yeah, I'd second that as well. So thanks, Nicola. And on to one of your team, Sally, infection prevention and control. Have you done much in the last 12 months?
No, not really. Just a little bit. Morning, everyone. So yes, the infection prevention and control annual report for last year. Very, very busy year for the infection control team last financial year. So general overview of the report. There were 57 outbreaks last year, all were COVID, nothing else, all COVID outbreaks. They were all managed and supported in the care homes by ourselves, public health. They were varying length and severity. The report doesn't go into too much detail of that at the moment, but this is just a general overview of what the COVID outbreaks were like, as you can have seen in the report in detail. The work as normal sadly didn't go away, so none of the other bugs did go away, so there was still the HCAR work that we needed to try and continue as business as normal. Officially trajectories weren't set by NHS England, but we were advised to try and reduce by one case on the previous year. So MRSA bacteremias, there is a zero tolerance against them, regardless of what else is happening. And we had no attributed cases to Bassetlaw last year. C. diff cases, so the previous year's trajectory was 26, so reducing by one would have took us to 25. And we were in trajectory, which is the first time for a number of years for Bassetlaw to be under a trajectory with 20 cases. So that was a positive. E. coli bacteremias, we had 75 cases against, again, the internal trajectory of 85 for the year. Not reportable, but we did have one PVL case that we monitored and managed well. sadly, our proactive audit programme didn't take place as we would have normally carried out due to obviously the COVID demands on our time and pressure and workload. So only 4 nursing homes, 5 residential and 1 younger adult home received a full proactive environmental audit. However, there were lots and lots of visits into lots of settings, obviously due to the COVID, so lots of support visits. It wasn't as if no one was in the homes, you know, we were going in and we were supporting. It's just that full in-depth environmental audit didn't take place, but we were in there doing lots of mini audits and things and supporting. Incidence of TB as reported by RDASH in Bassetlaw does still remain low, and last financial year we had 3 active cases of TB and 2 latent TB cases seen. Positives for the year, there was some donning and doffing training that was asked to be delivered in the space of 2 weeks in May, in the height of the first wave, for all our home settings, which included younger adults. And we did achieve that as an infection control team with support of colleagues from Notts Healthcare as well. So that was really positive that we managed to achieve that, and had some really positive feedback from providers, as you could probably see on page 18 of the report. There was a lot of appreciation from provider organisations and home care that really appreciated the training that we did for them and supported them with. During the outbreak, we decided to proactively develop an outbreak planning assessment tool, which we'll continue to work with the homes at the moment. So this is to plan for future outbreaks of anything, not just a pandemic or whatever new bug comes on the horizon. It's to help with any kind of outbreaks that they might get moving forward. So it's a little bit more in depth around cohorting, isolation, making sure they've got the right equipment available, and the donning and doffing stations are set up correctly. So it should be a really good tool for all the homes moving forward for outbreaks. And the infection control lead for the teams, that's myself, also joined a shared decision-making council with NHS England and Improvement. So this is to try and pull on the expertise of infection control nurses across the whole of the country, and help NHS England deliver the best processes and policies and guidance regarding IPC and help advise them and contribute to that. I think I'll stop there. Has anybody got any questions, comments?
Thanks. Thanks for that, Sally. Hessian.
Thank you, Sally. Thank you for the update. My question is more around COVID and any potential learning from your outbreak reviews. Has there been any learning around where the source of the infection might have been? Because there's lots of national data around where the seeding came from, whether it was hospital specific, i.e. following discharge, or whether it was seeded from the community, i.e. via staff or visitors, if you like. Or did you get any learning around whether there was any issues around PPE that could have potentially resulted in outbreaks, or cohorting, or not really understanding the guidance, etc., etc.? Because last year was quite a dynamic year with guidance changing fairly rapidly. And I feel for the care homes, it would have been a very challenging year for them. But in relation to the future, and in terms of preventing future outbreaks, as you rightly pointed out, whether it's COVID or something else, is there any learning that we've accumulated from reviewing those outbreaks that we could take forward for the future? Thank you.
Yeah, thank you. Yes, there is a lot of learning. Yes, so some of the learning that you've just mentioned, so visitors, visiting professionals discharging from hospital in the early stages, lack of PPE in the start was obviously a contributing factor, in the uncertainty around that and the anxiousness around that. I think in terms of the COVID, as everyone experienced. We didn't really know much about the bug and the way it spread and all that kind of thing to start with. So in relation to the care homes, they were kind of working in the dark to start with. So it was working through the guidance as it was coming out. I mean, in the very early stages, the guidance changed sometimes, 3 times in the same week. So it was trying to keep on top of that and help support the homes in putting that change into practice. So there is a lot of learning that's come from this that moving forward we can utilise and help support in terms of future outbreaks and things. Definitely, it's just pulling all that together and putting it in a format we can share.
Thank you. And has that learning been shared with the care home staff? And I suppose my supplementary question is, has that resulted in more care home staff having the vaccine? Because that's an area that nationally we've struggled with in terms of care staff not having the vaccine. Have we seen the same hesitancy locally? And if we have, has that improved throughout the year from the reviews that you've undertaken?
It has. In terms of the vaccination, I mean, we had the last outbreak that we had was finished in the middle of May. And the staff that were positive in that outbreak were unvaccinated. And it really did point out to the home and the importance to those staff that actually they do need to get their vaccination. So there's been a lot of learning. Each outbreak has had like a little mini root cause analysis and things like that we've worked with the home, and they've taken on board that learning. So it isn't just collected and it's ready to go now. It has happened as we've gone through the pandemic. So, the managers have taken on the learning that's been highlighted of how potentially it started and how it's transmitted around the home potentially. And moving forward, that learning will be embedded into hopefully future outbreaks if there are any, but we hopefully not. But but yes,
Thank
the
you very
vaccination stuff is really interesting. Yeah, it has triggered a lot of staff to go and get their vaccine since outbreaks and things like that.
Perfect. Thank you.
Thanks. Idris?
So this report sort of marks probably one of the most remarkable years that the health service has seen, and I suspect from Sally's perspective, one of the most challenging for her and the team. And I just wanted to say that I think that Sally and the team have behaved and responded in an extraordinary way throughout the pandemic, and it's something that personally I feel very proud to lead an organisation with people like Sally and a team in it, because it has been absolutely exceptional. I have no doubt whatsoever that lives and livelihoods will have been saved in large number because of the actions and the tireless efforts. I'm sure Sally at times felt very tired, but tireless efforts that have been put in. And people have increased their hours. We've had 7-day cover, carrying on with sort of a lot of the day job as well on top of COVID. Yeah. So I just wanted to mark the fact that actually this is a report that is exceptional in terms of both the effort that's been put in and the challenges that we've faced in the last year.
Thank you.
Thanks, Idris. And I would fully support everything Idris has said there, Sally. Your team has done a tremendous job. I look after a care home in Retford, and the management there speak incredibly highly of you. So from a practical point of view, it has been greatly appreciated, everything that you've done.
Thank you. It's good to hear.
Sue?
Idris beat me to it, but I just wanted to say very much along similar lines from the Quality and Patient Safety Committee. We really appreciated the assurance that Sally's been able to give us as she's talked to us throughout the year about the work that they've been doing, the success they've been having in the care homes, the support that they've provided. And I think they've done a truly remarkable job in really difficult circumstances. So thank you very much, Sally.
Thank you, Sue.
Victoria?
Yeah, again, Idris beat us all to it, and he's very eloquent. So, Sally, I can't add to any of that, but I just wanted to say, you know, you and the team have just done an absolutely amazing job, and really from the bottom of our heart, thank you so much. Thank you so much, because you really made such a big difference to what was a very challenging time for lots of people, but you really, really were there. You were a stalwart of support, protection, and ongoing encouragement to a range of people, not just care homes, but CCG staff as well. So just a big, big thank you to you and the team for all the hard work and the amazing effort that you put in.
Thank you. Thank you so much. You get me crying in a minute. Thank you. It's really appreciated, and I'll pass it on to the team.
Yeah, it looks like a round of applause to you. Well done, Sally. I think as a GPs, we are a bit embarrassed here, you know, because we didn't give antibiotic, and CDs has come down, and we have patient, and CDs has come down, and I can't get credit for that. I can tell you, Sally. Well done, well done.
Thank you.
Great. So Sally, excellent report, excellent work as ever from you and your team, and you are fully appreciated by not only members of governing body, but by the CCG as a whole, and that whole wider health and social care community. Thank you very much.
Thank you very much, and I'll pass it on to the team. Thank you.
Thanks. Looking at the agenda, we welcome Adele Spence. Adele, welcome to governing body. You're here to tell us about evidence-based interventions, commissioning for outcomes.
I am indeed. Thank you very much. So hi all, I'm Adele Spence, Transformation Lead for Urgent and Emergency and Elective Care at Bassetlaw CCG. We've been working with the fellow CCGs across South Yorkshire on the implementation of the Phase 2 Evidence-Based Intervention Programme, which is subsumed within our local South Yorkshire and Bassetlaw Commissioning for Outcomes policy. So the purpose of the paper is to ask governing body to note and approve the revised policy, taking into account the 31 additional tests, treatments and procedures that the clinicians and commissioners for primary and secondary care nationally have developed, setting out interventions that have limited clinical effectiveness and therefore need to have restrictions placed on them as to when they are applied. So there's probably not much more to add by way of summary over and above the paper that has been provided. So again, it's just to ask you to approve the policy, and obviously if there's any questions that you wish to ask, then I will do my best to give an answer to you now.
Thanks, Adele. Heshen, any questions?
Thank you, Eric. Yeah, you beat me to it. Yeah, again, I think those were all my questions already, because I've raised the same questions at various forums, really. I suppose I'll start off from a governing body perspective around consultation. So, and again, this is probably more for Sam and Sue as well to give your view. Am I right in thinking there's been about 450, circa 450 responses from the public around EBI Phase 2? Is that right?
Yes, that thing. Yeah, based on the information provided. Yes.
And again, correct me if I'm wrong. The population of South Yorkshire and Bassetlaw is about 1.5 million. Is that right?
Yes,
is that correct? Yeah, that's about 0.03%. in terms of the public that's potentially been consulted. I'm not quite sure whether that's a good figure or a figure that could be potentially improved upon. I suppose the other question is, do we know how many patients who are currently on a waiting list across South Yorkshire and Bassetlaw? I suspect there'll probably be in the thousands, potentially. Have we had a missed opportunity in terms of trying to see whether we could have reached out to those patients potentially? Because some of them would have had a vested interest in terms of making a comment in terms of this process. Some of their procedures may have been brought forward because others would have dropped out of the waiting list, and some procedures may have been cancelled potentially according to the new system. So I wonder whether again, I don't feel entirely reassured by the public consultation element of it, to say our public are behind us in terms of this. And that's not saying that I disagree with some of the clinical principles that have been highlighted, but if we're saying we're truly engaging with the public and patient participation, that's probably an area that potentially a missed opportunity, if you like. The other thing that I've kind of mentioned to you, Adele, is have we had any confirmation from Secondary Care Trust whether EBI phase 2 would be retrospectively applied to try and review the existing waiting lists and what happens to those patients? Because I don't think we've had any clear steer from secondary care around that. And my third thing is that even if we all agree as clinicians that this is the direction of travel, the phasing in of this and how do we manage the patient interface, because a significant number of these procedures are not directly linked to a primary care referral. They're related to secondary care interface and diagnostics and how they manage patients in secondary care. And if our secondary care consultants, and again, if assuming a proxy measure in terms of the consultation uptake, in terms of the 443 responses, how many of our hospital consultants locally have potentially been consulted and have been supportive of a implementation process around this? Because what me as a primary care clinician didn't really want is a patient being stuck between primary care and secondary care because someone says it's someone else who needs to fill in this form or what. And again, in terms of learning from EBI phase 1, one of the misunderstandings that came from secondary care was secondary care had the impression that only primary care could fill in the clinical thresholds, and that they couldn't, and therefore lots of patients got bounced back to primary care, even for things that could have quite easily been managed in secondary care. And the second misinterpretation was that lots of primary care patients were not even seen by secondary care because they felt that a clinical thresholds needed to be filled in even for asking for an opinion. And the opinions were rejected as well, based on the fact that some patients didn't really have the clinical thresholds filled in. And I'll give you an example in terms of hemorrhoidectomy. Lots of patients with hemorrhoids don't need an actual excision of an hemorrhoid. They can be managed through banding or injection. But in order for me to refer for banding or injection, I need to fill in, or the impression that was given was I need to fill in a threshold for hemorrhoidectomy, which the patient doesn't qualify for anyways. So there's all these nuances that could be managed quite effectively if we, across primary care and secondary care, work collectively together. And that's the other bit, having spoken to several colleagues in Doncaster Bassetlaw Hospital and beyond. I haven't, again, hand on heart, I haven't seen a universal kind of acceptance in terms of, yes, we've been consulted, we are kind of on board with this process. It very much is seen as a commissioner-driven process, which I'm not quite sure whether it's a more successful way of actually progressing this, considering the conversations that we've had in terms of the current block contracts and difficulties that commissioners will have in terms of creating transformation within a block contract. If we do things through consensus and agreement, I think we'll have far outreaching kind of positive consequences, as opposed to trying to say this is commissioner driven and therefore it is a must do. It may be a must do from a national perspective, but I think implementation wise would require both parties, primary care, secondary care, and patients all to come together. And I'm not sure, unless someone tells me otherwise, the data that's been presented, I'm not quite sure, and the ones that I've seen outside this meeting, I'm not quite sure whether all three parties have come together into a single point. And that's what I've said on various other committees, and I'm saying the same thing in governing body, really. So it's nothing new. So I'd be more than happy to be reassured on all those points. Thank you.
Thank you, Hesh. I noticed Victoria had popped her hand up. Victoria, do you want to come in before I respond to Hesh?
Yeah, happy to. Thanks, Adele. Thanks, Hesh. And as usual, Hesh, eminently sensible queries, thoughts, comments, and reflections. You're absolutely right. So this is something that has been driven on a national footprint. So these amendments are being part of the national contract for NHS providers. So we're asked to basically confirm our acceptance of the policy locally. As part of that national agreement process, and those consultation engagement with our national leaders in various royal colleges, as well as patient and public consent, has already taken place with that national process. You're absolutely right, however, that we would benefit from having local conversations with our clinical colleagues, both from across primary care, community and acute, to ensure that our implementation of these policy and expectations absolutely do marry with our own understanding of our pathways and patient concerns and patient safety. So the suggestion that we've had on an SYB footprint is that we take forward that implementation, that phased implementation together on an SYB basis. So again, we are supporting equity of treatment, equity of access for patients, as you would expect us to do, acting on a system basis. So the current recommendation is that the acceptance of the policy is one thing, and governing bodies is asked to accept that. But the implementation phase is something that we need to take forward with the oversight, hopefully, of the Elective Oversight Board, which is predominantly, as you know, supporting the work of our provider organisations coming together. And basically with that oversight, I think, therefore, we can have much more richer conversations with our acute colleagues. That also doesn't inhibit us locally having direct conversations with clinicians in Bassetlaw and with Doncaster acute colleagues as well, and involving Doncaster CCG colleagues. So those pieces of work can now continue. And in fact, if we do that, I think we'll be acting at the vanguard of some of those conversations, and then we can share the learning of that more widely with other acute colleagues as well, to get that consistency of approach wherever we can. So I think, Hesh, you're absolutely right. There's lots more conversations that need to be had around the implementation. But I think for the governing body at this moment in time, we just need to accept, and I would commend the acceptance of the policy as it's written, on the proviso that we do take those conversations forward.
Thank you, Victoria. I don't think I have much more to add to that. It was perfectly succinct. I can reassure members of the governing body that Hesh and I do work closely and have worked closely on this, so I was aware of the queries he would raise, and these don't, that's notwithstanding the request for approval today. So absolutely, it's one thing accepting the policy, it's another implementing it, and lots of work will be done around that in both primary and secondary care to make sure that it's fully implemented. The dates by which they will go live will be discussed and agreed. We will make sure that patients are not stuck in the middle, that there are comms to cover all parties, that patients don't go missing between one or the other. It's not one it's a national programme, so it's not about the CCG have decided or secondary care are doing this or whatever. Absolutely recognise your points about some of these are not initiated in primary care, therefore secondary care are responsible for the checklist, and we will continue to re-clarify that. And asking for opinion, where you're asking for opinion, you don't need a checklist. So again, we will continue to work with primary care, picking up any examples where secondary care have not quite followed the correct policy, and vice versa. And we'll try and work with both parties on that for the benefit of patients. And I guess the last point I perhaps might make is we've been looking at the activity levels for the procedures and the anticipated trajectory, the anticipated reduction that might be expected, and we're not that far off actually for many of them. So that might mean that it doesn't really require much in the way of a change of behaviour, that these are guidance. This guidance is already being followed in practice, but rather it's standardised and hopefully made easier, and certainly standardised across the country, and therefore that may mean the impact on the waiting list is not that high. But again, that's linked to the date from which they will apply, and that's to be discussed. So I will continue. I appreciate that's perhaps not perfect answers to everything you've raised, Tash, but promise to continue working with you to provide that reassurance, and we can give further update if that would be welcomed by a governing body. Thank you.
Thanks, Adele. Kumar, you've got your hand up.
Yeah, thank you. I think all the points are covered. I think I'm happy with the national intention. It's the local implementation which really kind of sometimes contradicts the whole purpose. And I have similar patients who had a torn cartilage after an injury, and they said it's rejected because I'm asking for a knee replacement. No, she's got a torn cartilage, he needs a cartilage repair. And I sent an email back to Andy. And I think if you want primary care clinicians on board, and I think CCG have to support, not now as well as going forward. So I think there's a good way of communicating when this happens, to communicate with CCG how to sort these things out. And at this point, the process goes to IFR process in Sheffield. Then I have to speak to IFR team in Sheffield, when it is kind of utter waste of time, I'm afraid, because if somebody injured his knee with a torn cartilage, I'm talking about knee replacement. So I think it would help primary care physicians if you're able to give a CCG email address where you could take it further. That would really help. And then you have more support from primary care physician, because we understand where you're coming from. We want to support, and we need to be supported by CCG, and any help will be appreciated. Thank you.
Thanks, Kumar. Any other quick points? Nope. So as a CCG, are we happy to approve this paper? I will take raised hands as unhappy, down hands as happy. I can't see any raised hands, so Adele, it's approved by governing body.
Thank you very much.
Thank you. And thanks for joining us this morning. Jumping back to the agenda, I think we're down to any other business.
No, we've got the audit committee update first.
Oh, sorry. Oh, I do apologise, Sue. I apologise.
I won't be very long, but it really needs to be said. We've had the results of the external audit and the completion of the internal audit and the sign off of the accounts. And as you would expect, the standard of the accounts has been as high as ever. And I think I noted at an earlier committee that they've had to produce those accounts at a very difficult time because they were also doing the financial planning. But the feedback that we got from the auditors was just excellent. They recognised the quality of the work and also the responsiveness of the staff and the help they'd had with the audit. And all round, it was just a pleasure to be in there and to listen to the feedback that we were given about the quality of the staff and the work that they'd done. There were hardly any amendments, very minor little details that were made, and so we've got a clean opinion. The VFM area was new this year in terms of a different approach, so we don't get an opinion as such, but they raise any significant issues. Unsurprisingly, at the planning stage, they'd raised financial stability, and I think that was common across the board, but they were satisfied by the arrangements we had in place to mitigate that, and so there were no significant issues raised. And again, that is not common across the board. Other places will have had issues raised in relation to that. So actually, we've got a brilliant outcome, and thanks a lot to everybody involved, not just the finance team, but those involved in pulling together the annual report, Cheryl particularly, and really we couldn't have had a better result. The only other thing that we considered that I just wanted to raise was the counter fraud framework. They've changed the framework this year. Well, it's actually changed for April onwards, but the self-assessment was done based on the new criteria to set a baseline. So unusually for us, we had a couple of reds and a few ambers, and I felt, and I think the audit committee all felt, that it was a bit disappointing because it doesn't really give a fair reflection of the CCG's commitment to anti-fraud. However, it's new national guidance, everybody else is in the same boat. It's setting a baseline, and there was no way we could have complied. The reds could only be red this year. So I just think it was worth noting that it is not an accurate reflection of our approach to fraud and corruption. And the feedback we were getting is that with the work we've got planned, there's no reason why that won't improve significantly when the time they come to assess it at the end of the year. And we're in a very consistent place with everybody else. Happy to answer any questions.
Thanks, Sue. Victoria?
Eric, sorry, it does relate to the report around audit, but it was something to raise under AOB as well. So I don't know if you want me to leave it until formally under AOB, or you want me to carry on now.
I don't think there's anybody else queuing up to ask questions, so you might as well carry on. I just, it's a bit of a reflection really, and a bit of a query. So my reflection is we have now consistently commended, haven't we, the work of CCG staff on a number of fronts that has been undertaken at extremely challenging times, and I think we all agree that. And we have, as an organisation, continued to perform in an excellent and outstanding manner. And hopefully NHS England's report on that will be consistent with that approach as well. So that's my reflection. I think my query to governing body is, obviously, given the wider changes that are happening at a system level as well, and the impending changing nature of the CCG as an organisation, do we as governing body want to reflect and think about how we mark the dedication, the support, the commitment of our staff, not only throughout this troublesome year, but also as we move forward into new horizons and new ways of working, just to basically do something that is a bit of a stock take, but also a thank you as well to staff before we move on to pastures new in terms of the way that we are organised and staff move on to different employment arrangements. So it's my question to governing body is, can we put some thought into how we might want to mark as a governing body both the transition arrangements, but also the reflection of the hard work undertaken and the excellent standard and commitment that's been achieved? So can we put some thought to that, please?
Thanks, Victoria. Idris?
I think it's a really good point. I think I'd really be interested in suggestions. Obviously, a party is probably not the option to consider at the moment, but I think at the very least, and I'm not limiting it to this, I'd like to hear sort of other people's sort of ideas and suggestions. We should do a letter from governing body to all staff, just commending them, and I think it is both, as we've heard today, about keeping the day job, sort of going, and not just ticking along, but actually, so we've worked exceedingly well, sort of despite that, and issues like the quality aspects and the audit controls, the good financial controls, the good organisational governance, are some things that other organisations perhaps haven't been able to do, or haven't done as well as we have been able to. And for a small organisation, I think that's incredibly commendable for all our staff. So we could kick off the idea of, well, how do we mark this, and how do we sort of communicate this, and what do we do with our staff? But we could kick it off with a letter, perhaps, that goes formally from governing body to all staff, expressing sort of both the gratitude and the praise, so that they deserve. But I'd be interested to hear ideas in addition to that.
Thanks, Idris. Sam?
It was just to follow on from that around whether we should take some suggestions to a REM committee address and have a discussion there, and Sue bring some proposals back.
Yeah, I think that would be an excellent idea, Sam. Have we got one coming up?
No, they're organised on an as and when basis, so I can just fit one in at some point if somebody wants to give me a timeline.
Well, can we do something in the next 4 weeks, please, Linz?
Yeah, no worries. I'll get something put in.
Okay. Thank you. Thanks. Any other business? No. Well, I will bring June's formal public governing body to a close. Could we stop recording now? It's 10:35, 5-minute break in reserve.